Thank you for the invitation. So just to disclose, my work is majorly sponsored by US government, by different agencies, and also I work and consult for several societies such as RC, ACR, Infectious Disease Society of America, American Association of Neurology, and also Royal Australian College of General Practitioners and others. So as we all know, osteoarthritis is the most common cause of chronic pain in older people, and also it's the leading cause for disability. And the prevalence of osteoarthritis varies across many countries and also various study populations. And it was kind of estimated to be a prevalence of knee and hip OA has been estimated to be around 0.5 to like up to 36% in certain populations. And as we all know, there is a rapid increase in knee osteoarthritis prevalence, not only just in US, and also across the world. And as we know, the entire world population is aging, and also there's a huge obesity epidemic across the world. So because of these two main reasons, the prevalence is increasing rapidly. And also there's considerable economic and societal cost. I mean, I just put in the numbers from US, but I think it is a huge economic burden on the entire world economy. And as we all know, currently there's no effective disease-modifying medical intervention, and also the lack of comprehensive comparative effectiveness studies that look at all modalities is making informed treatment decisions very difficult for all of us. So in this talk, I would like to kind of explore and also present to you how hyaluronic acid compares to other osteoarthritis treatments. And I'm going to highlight this study, and also I'll be pulling data from a few other studies. I mean, this is a study which compared effectiveness of several pharmacological interventions for knee osteoarthritis. And they looked at, I mean, I should say, we looked at, because it's our study. So we looked at acetaminophen or paracetamol, and also compared it against several commonly prescribed NSAIDs such as diclofenac, ibuprofen, naproxen, celecoxib, and also we looked at most commonly and widely used intraocular treatments such as steroids and hyaluronic acid. And just to complete this kind of comparison, we need the intraocular placebo and oral placebos of these trials. And the primary outcome measure of this study was change from baseline in pain scores, and this was looked at 3 months follow-up from baseline. In this study, we included about 137 trials and randomized controlled trials, which randomized about 33,000 patients, and the mean age of these patients was between 60 and 64 years. The percentage of women in these studies ranged between 62 and 72, and the overall quality of these studies was moderate. So this is just a pictorial representation of a network of treatment comparisons for pain outcome, and the size of this circle indicates the total number of participants randomized to that treatment, and the size of the thickness of the line represents the number of studies or trials comparing those treatments. And if there is no line connecting two circles, that means that those two treatments were never compared in a randomized controlled trial. As you can see, we have several treatments compared against each other, and some were not compared against each other. But then the beauty of this methodology is that we get to get the comparative effectiveness of the studies or the treatments which were never compared against each other. For example, here I can give you an estimate of efficacy of hyaluronic acid versus celecoxib, where there is no randomized trial performed comparing these two treatments. And just jumping right into the results, what we found, just to orient you on the leftmost column. So these are the comparators, and I'll help you how to read this. So, for example, in the first row, what we have is the effects of these treatments compared against oral placebo. So, for example, compared to oral placebo, intraocular hyaluronic acid has the highest effect size, which was 0.63. And acetaminophen or paracetamol had an least or the smallest effect size of 0.18. And the interesting finding in this study, what we found was acetaminophen and celecoxib were pretty much the same. So that means celecoxib was non-inferior to acetaminophen. And the other interesting finding from this study was intraarticular placebo was so superior that only intraarticular treatments such as steroids and hyaluronic acid were the only ones which were statistically significantly better than intraarticular placebo. And as you can see, all the NSAIDs we looked at, celecoxib, naproxen, or ibuprofen, or diclofenac, they were all not superior to intraarticular placebo. What we all know is they are all superior to oral placebo, but not intraarticular placebo. And also, another interesting thing what we found was certain NSAIDs, like celecoxib and naproxen, they were inferior to intraarticular hyaluronic acid. To put it in other words, intraarticular hyaluronic acid was superior than celecoxib and naproxen. And you can also see that it was also kind of superior than ibuprofen and diclofenac, but that was not statistically significant. But definitely against celecoxib and naproxen, we were able to show statistical significance. And just to kind of put this in the context of patient perspective, we looked at the change from baseline. That means this is what a patient experiences. So, for example, as you can see, if you prescribe acetaminophen or paracetamol, they'll be looking at a 20-point change from baseline. That means if they had a pain of, let's say, 60 at the baseline, it'll come down to about 40 in about 3 months. So we did that for every treatment. As you can see, intraarticular placebo has an effect size about 22 points on a 0 to 100 scale. And this red line, I would like to kind of alert you to that, is that represents a 20-point change, and that's the line of minimally clinically important significant effect for a patient. And that represents, in the context of the baseline, it's about close to 40% change from baseline. So any treatment which is falling beyond that is for a patient, for that patient, now we're not comparing against placebo or anything, just for the patient, if you give the treatment, they're getting this much of benefit. So as you can see, except acetaminophen and intraarticular placebo, every treatment is giving us a good amount of improvement from baseline. And the beauty of this analysis plan is that we can even run millions of simulations, and we can rank these treatments. So as we did that, we found that the intraarticular hyaluronic acid has been ranked either number 1 or number 2 in 90% of the simulations. We ran about 5 million simulations on this one, and when we averaged it, in the 90% of those simulations, this intraarticular hyaluronic acid was ranked number 1 or number 2. In contrast, naproxen, as you can see, it was mostly ranked between number 4 and number 6. So, what is the difference? What did we do different? Why are we finding a huge effect of 0.63 for hyaluronic acid, and where somebody else is finding an effect of 0.3 or 0.34, and then they say, oh, you know what, that's not great, and why I'm saying that it's great. So what we did is we looked at the comparative effectiveness versus a common comparison. So, and this is more like a pragmatic approach, and I'll kind of explain that with a simple example. For example, if you want to look at celecoxib versus hyaluronic acid and want to know which one is better. So what we have is in a traditional way, we say celecoxib versus oral placebo, we have an effect size of 0.3, and then hyaluronic acid versus intraarticular placebo is 0.4, and we just look at 0.33 versus 0.34 and say, oh, they're equal. But then the network actually compares and gets an estimate of hyaluronic acid versus celecoxib. And the network shows hyaluronic acid is better than celecoxib with an effect size of 0.30. And this is what a patient experiences. This is close to what a patient can experience with these kind of treatments. So, and coming to the safety, the most commonly reported adverse events among these intraarticular therapies were transient local reactions such as pain, swelling, arthralgia, and these subsided within few days. And these events were kind of reported to be similar between intraarticular therapies such as steroids and hyaluronic acid. So now I would like to kind of show you how the efficacy of hyaluronic acid varies over time. In this study, we included 54 randomized trials, randomizing about 7,500 patients with knee osteoarthritis, comparing HA versus intraarticular placebo. And we computed effect sizes from week 4 to 6 months. So the effect sizes kind of favored hyaluronic acid by week 4, and then they reached peak at week 8, and they started trending down, and still they had a residual effect even at 6 months. So this is the graph. So as you can see, yeah, we have a significant effect at 4 weeks, and then it peaks around 8 weeks, but then it starts going down. But you still have like significant effect up to 6 months. And we also wanted to see how does hyaluronic acid compare against intraarticular steroids. So what we found was, I mean, again, just to orient you to this graph, the effect sizes in the with the negative effect size favor the steroids, and the positive effect sizes favor hyaluronic acid, as you all kind of expect. So the steroids are effective around 2 weeks, so they are better than hyaluronic acid at 2 weeks. And then by 4 weeks, they both are equal, and then beyond 4 weeks, hyaluronic acid is better than steroids up to 6 months. And I mean, you all would wonder, like, who would be the right patient, and which kind of patient would be ideal for this treatment. And in this study by Noy et al., they found that if you choose to inject a KL2 patient, the probability of that patient achieving more than 50% reduction in pain is about 71%. And if you inject a KL3 patient, that probability is about 62%. If you inject a KL4 patient, that probability is about 42%. That means there's a 42% chance that somebody with KL4 would get a 50% pain reduction, pain reduction from baseline. So even that's a good proportion of patients would benefit. I mean, a good proportion of KL4 patients would benefit with this kind of drug. So I would like to quickly kind of take you through the latest RC 2019 recommendations, and I would like to kind of talk to you about them more in the perspective of where hyaluronic acid stands and where hyaluronic acid would fit into the treatment algorithm. So, I mean, this iteration of RC recommendations, we have co-treatments for knee osteoarthritis, and these are like arthritis education as standard of care, and then we also recommend structured land-based exercise programs, such as strengthening cardio or balance training, neuromuscular exercises, and also type 2 exercises, which are mind-body exercises, including Tai Chi and yoga. This is kind of a new recommendation. So where we recommend mind-body exercises, including Tai Chi and yoga, as kind of co-treatments. And then we also recommend dietary weight management with exercise as a co-treatment. So I would like to just give you a quick highlights of the RC recommendations. So as I said, mind-body exercise is core for knee osteoarthritis, and topical NSAIDs are strongly recommended for knee osteoarthritis, and hyaluronic acid is conditionally recommended for knee osteoarthritis. Certain oral NSAIDs are not recommended within specific comorbidity classes. So this iteration of RC recommendations are divided into, I mean, we have multiple patient profiles. So for somebody with knee osteoarthritis and no comorbidities, that's one kind of patient. And then we have patients who has GI comorbidities or cardiovascular comorbidities, or somebody who has like widespread pain disorder, including depression. And then the paracetamol or acetaminophen is not recommended anymore. Opioids are not recommended anymore. So these are like the key highlights of the RC recommendations. And then I would like to just quickly present a case. I have like 15 seconds, but I'll quickly go through it. So in this patient, I mean, we have a knee osteoarthritis patient. This person has hypertension and overweight. So as per the RC algorithm, what we ask people is to kind of, I mean, the physician has to assess the clinical status, which is the pain, function, and stiffness, and also look at if they have effusion, instability, or malalignment, and also assess the emotional and environmental status of the patient. And then they'll be picking the core treatment, which is the structured land-based exercise and dietary weight management, because that person is overweight. And then once we have this initial assessment and then we have picked the core treatments, we move on to the patient-centered pathways, which is for this patient. I mean, again, like since this patient has knee pain, we would say like, okay, since topical NSAIDs are strongly recommended, we will ask you to pick topical NSAIDs, but then you still continue your diet and weight exercise management. And then you reassess the patient as needed, and then if the patient is in an acceptable state, you continue the same treatment. If not, you might move on to the secondary options. For example, here you can try aquatic exercise, but still maintaining the other exercise and diet. If that doesn't work, you would reassess again, and then you'll say, okay, try steroids. Or you again reassess, and then say, now you can try hyaluronic acid. And then you can assess again. If none of these are working, I mean, you kind of go through the entire list of treatments we have. When you exhaust all of this, that's when you go, okay, so now you reassess the diagnosis and also have a pragmatic discussion with the patient, and then consider referring to the pain clinics, and then also like maybe the orthopedic surgeons. And yep, you keep reassessing these people regularly, and then you need to take them, make pragmatic assessments. And if one caveat here is like if you're choosing steroids or hyaluronic acid, we also said that intraarticular steroids are recommended for acute and kind of a short-term, like up to 4 to 6 weeks pain relief, whereas hyaluronic acid is recommended for long-term pain relief. And if you had to choose NSAIDs in this patient, the RC statement says that lowest possible dose of NSAID for shortest treatment of duration, which is about 1 to 4 weeks, along with gastric protection with a PPI, is kind of recommended. So just the take-home messages, hyaluronic acid is more effective than NSAIDs. It has long-term benefits than intraarticular steroids. Repeat courses have been shown to be beneficial, and they can be combined with NSAIDs or physical therapy, and it's well tolerated with few serious adverse events, and it's indicated in patients even who failed other therapies. Right. Thank you.